Hello everyone. Today I am going to share with you a very unusual case of what looked like a classical case of fungal corneal ulcer but turned out to be something entirely different. So I have named this presentation as Not All Ulcers Are Corneal, and there is no financial interest in the subject matter. So our patient was a 27-year-old male who complained of gradually increasing white spot in his left eye. He had a history of therapeutic penetrating keratoplasty 5 years back. The graft had failed subsequently. There was no perception of light, and on slit lamp examination, a central 3 mm by 2.5 mm grayish white lesion was seen with striking resemblance to a corneal ulcer. So this is the magnified view, and on the face of it, it looks like a classical case of fungal corneal ulcer with characteristic of grayish white infiltrates, feathery margins, and the infiltrate involving the center of the pupillary area. However, on further probing, he disclosed that he is actually using a brown colored cosmetic contact lens for past several years after his graft had turned opaque. So then we removed the contact lens, and underneath we could see an opaque graft with extensive superficial vascularization. So the infiltrate was not on the surface of the cornea or in the corneal stroma, but it was on the contact lens. No epithelial defect or underlying infiltrate was noted on the underlying opaque graft, and he told that earlier he would visit his nearby eye clinic to get his contact lens cleaned regularly. However, for some reason, for the past few months, he couldn't visit the clinic, and he had been using this cosmetic contact lens continuously. So scraping of the material from the contact lens surface revealed broad, sparsely separate fungal hyphae on 10% KOH smear. As a prophylactic, antifungals were prescribed for a couple of weeks, and these were ultimately discontinued after ensuring that there was no infiltration of the cornea on the follow-up visits. Keeping in mind his lack of hygiene, he was advised to discontinue contact lenses, and for cosmetic rehabilitation, corneal tattooing was done, which offered a good cosmetic outcome post-operatively, and he could continue with his life and his work. So, lack of hygiene, excessive eye rubbing, steroid use, or inadequate disinfections are major risk factors which can lead to fungal invasion of the cosmetic contact lenses. There have been very few scattered case reports of fungal invasion of contact lenses, and this is probably first in which we could find a cosmetic contact lens with fungal infiltrate and masquerading as a fungal corneal ulcer. So this case highlights the importance of patient education regarding cosmetic contact lens hygiene, the need for regular replacement, and opting for alternate options like corneal tattooing in non-compliant patients. So remember, not all ulcers are corneal. So this case was published in Indian Journal of Ophthalmology with the title Fungal Invasion of Cosmetic Contact Lens Mimicking a Corneal Ulcer. And I would like to acknowledge the contribution of my younger colleague, Dr. Gaurav Mahajan, in putting this case together and helping in publishing it. Thank you very much for your attention.